Professor Dominique Lerousseau, you presented here at the Congress the 5-year overall survival data of the Paola trial. Can you walk us through the study results?
Sure. As you know, Paola trial was a randomized phase 3 trial evaluating the combination of olaparib plus bevacizumab versus bevacizumab plus placebo in patients with stage 3-4 high-grade serous and endometrioid ovarian cancer treated in first line with platinum-based chemo plus bevacizumab, and if this patient experienced at least a complete or partial response to chemo, they were randomized to receive the combo or the single agent. The primary endpoint of the trial was progression-free survival, and the key secondary endpoints were overall survival and progression-free survival too. And as is in the public domain, the trial met all the endpoints, and a significant increase in progression-free overall survival, MPFS2, was reported with the combination of olaparib plus bevacizumab in T-BRCA mute patient and HRD population. Yesterday, we presented a subgroup analysis, which was an exploratory analysis evaluating the benefit of the combo according to the clinical risk group, splitting our patient in high risk and low risk, where the definition of low risk was a stage 3 patient without residual tumor at primary surgery, and the definition of high risk where all the other setting of stage 3 and stage 4 patient. And what was evident, even with the delimitation of a descriptive analysis, not alpha located, and also there were not a huge number of events in some subgroup analysis. But what was evident is that the clinical risk is not able to predict the efficacy of the combo. I mean, the combination of olaparib bevacizumab in the maintenance setting should be offered to all patients with HRD tumor, irrespective of clinical risk factor. But it was very interesting to see how in low-risk patients, more than 90% of these patients, T-BRCA or HRD positive, were alive at 5 years after completion of chemo, thus suggesting that potentially for this patient we can speak about cure, which was a research quite unpredictable a few years ago in advanced stage ovarian cancer.
So how do you explain that the effect of the combination therapy were largest in the patient group which had the lowest risk of progression?
You know, it's a very complex question because we have potentially two answers. One answer is that probably the combo works better in patients without residual tumor, and in that situation we can potentially achieve the cure of the patient. Another explanation, more interesting to me from a biological point of view, is that that research is the combination of two factors. I mean, a particular weakness of the control arm in the lower risk patient, because previous data suggest that bevacizumab works better in higher risk population, so probably in this patient population the control arm is less effective. This can explain in part the results, but in my opinion there is also an additional factor. I mean, a particular strength of the experimental arm in this patient, because subgroup analysis coming from other trials using PARP inhibitor in ovarian cancer has clearly reported that when the residual tumor is absent or minimal, the efficacy of PARP inhibitor is larger. So in this case, we have HRD positive patients that by definition gain benefit from PARP inhibitor, and in the best clinical situation without residual tumor. This explains, in my opinion, a particular effectiveness of the combo in this group of patients.
That's very interesting. Yesterday, your colleague, Professor Gonzalez Martin, also presented a study for another PARP inhibitor, niraparib, in the Prima study, where he also concluded that the progression-free survival data were statistically highly significant. How would you will you try to compare these two studies, the use of the monotherapy in niraparib versus the combination therapy with olaparib and bevacizumab?
You know, this is the most important question of the last 3 years, because we have 2 randomized phase 3 trials, one evaluating the benefit of the combo and reporting the benefit of the combo in HRD patients, and the other evaluating and reporting the benefit of the single agent in the all-comer population, even though the benefit is larger in HRP. How to manage? In my opinion, at the end, in the absence of direct trial comparison, evaluating what is the added benefit of bevacizumab in T-BRCA and HRD positive patient to PARP inhibitor alone, what we do now is to evaluate the clinical characteristic of the patient, the molecular characteristic, the tumor characteristic in terms of neoadjuvant chemo, residual tumor, or whatever, and to try to personalize treatment accordingly.
So you have, as you're saying, 2 very effective therapies, which has to be adjusted to the patient's needs.
Absolutely, yes. We will have in the coming years the results of 2 randomized trials evaluating the single agent or the combo in HRD patient, and probably we will have the level 1 evidence suggesting if this patient should be treated with mono or combo. In my opinion, there is not a single answer. Not all the BRCA mute patients should be treated with the combo. Probably, in my opinion, for most of them, single agent PARP inhibitor is enough. But on the contrary, not all the HRD patients should be treated with the single agent. There are some patients in which the combo may gain 90% overall survival benefit at 5 years. So it's always good to have more option for the patient and to try to identify the best treatment for the best patient.
Last question, Professor Mirza Reza, he said that the Paola-1 study lacks 1 study arm. It should have been a study arm with olaparib as a monotherapy. What was your reaction to that?
Yes, if we have the third arm, PARP inhibitor alone in the Paola-1 trial, and if we have an active control arm and not placebo in PRIMA trial, probably a lot of questions have already had an answer in the last 3 years. Unfortunately, when you start thinking about the trial, you start designing a trial 2 years before the trial starts and 4 years before the results arrive. So sometimes we are not so proud and not so foolish to identify and visionary to identify where the clinical research will move. And now we have a lot of question, unanswered question for our patient. But I'm sure that in the coming years we will have the answer to this question. But by the time being, more possibility and the option to personalize treatment for the patient is always good.
Professor LaRosa, thank you for being with us.
It was a great pleasure. Thank you so much.
Thank you. Excellent.